Hello, I'm Ailsa Richie. I'm one of the ophthalmology consultants at St Thomas's Hospital, and I'm going to talk to you about paediatric ophthalmology. So I'm going to talk a little bit about the team that we have here at St Thomas's and the services that we offer, and a little bit about normal child development, and then go through some common conditions that we frequently see and some what not to miss scenarios. And then there'll be some time for questions and discussion later. So the paediatric ophthalmology team at St Thomas's, we have a large team of orthoptists, some of whom have extended roles, and they see children and adults. We have optometrists who also see children and adults and provide our contact lens service for children. So we have contact lenses for babies who are aphakic post cataract surgery, and we also have a lot of patients with keratoconus who are under their care as well. We have a family clinic liaison officer who is very helpful in liaising between the ophthalmology clinic and schools and families of particularly patients with low vision. And we have ophthalmology consultants. I am one of them. I also look after adults as well. My colleague, Mr. Lewisham, is our clinical lead at the moment, and he looks after paediatric patients. Mr. Danny Morrison mainly looks after paediatric patients, also has an adult oculoplastic clinic, and Professor Hammond is an academic who does our paediatric neurofibromatosis clinic at Guy's Hospital. So we see general paediatric patients in most of our clinics, and we look after patients with common conditions such as amblyopia, refractive errors, squint and abnormal eye movements, reduced vision or poor visual behaviour in babies and children, watery eye problems, orbital pathology, eyelid pathology. We provide a service for patients with congenital cataracts, and we operate on babies at a very young age. And we operate on patients with congenital glaucoma, also at a very young age. We have a lot of patients who have syndromes, who might be under the care of our Evelina colleagues, and we work closely with a lot of Evelina subspecialties to look after these patients. Patients with retinal dystrophies are also seen here, and we have a large range of imaging modalities available to us. And then any other eye disorder in children, we're very happy to see a minority we may refer on to other colleagues. We also have close working relationships with our paediatric neurology colleagues, and we do see patients with non-accidental injury and trauma. We do have subspecialty clinics as well. So we have allergic eye disease and keratoconus, which is a subspecialty that I take the lead on. And we do cross-linking in children with keratoconus, either under a general anaesthetic or a local anaesthetic here. We have a joint ophthalmology rheumatology clinic. So any child with uveitis, if it's a new diagnosis of uveitis in childhood, they normally are seen within a week, because this clinic is once a week. And they have an ophthalmology assessment, and we can easily get a full rheumatology review and get patients prepared for systemic immunosuppression very quickly if necessary. So we have a very good setup here for that, and Mr. Amaya and I are the ophthalmologists involved in that clinic. We have a cystinosis clinic, which is a multidisciplinary clinic, which we're all involved in, as is the cocaine clinic. As I said, the neurofibromatosis clinic, my colleague Professor Hammond is the lead on that. We have Bardy-Beadle and von Hippel-Lindau clinics, which have involvement from our adult medical retina consultants and Mr. Danny Morrison. And a genetics clinic is also run by Mr. Morrison with the genetics team at Guy's. We have an orthoptic-led suspicious disc clinic, which I will talk a little bit more about later when I talk about suspected papilledema. And we have a virtual clinic for hydroxychloroquine screening and low vision clinics. We also do ROP screening and ROP treatments. And we have an eye casualty. which is available for children. And the details are on here. So just to talk about normal child development, first of all. So a newborn child has a visual acuity of approximately logMAR 1.6. And this is because there's foveal immaturity, lack of myelination of the optic nerve. There's a lot of learning that has to happen, and cortical maturation. So by the time babies are 3 months old, the vision is around logMAR 1.3, and at 18 months, a normal vision will be logMAR 0.6. And it's only at the age of 5, really, that children are consistently have a logMAR vision of 0.0 or 0.66. So if you're seeing a child who's, say, the age of 4, for example, maybe a young 4, and they're getting a visual acuity of logMAR 0.2, that's still within normal limits. So it's completely reasonable to monitor these patients, obviously sensible to do a cyclopedic refraction and ensure they don't have a significant refractive error, but very reasonable to monitor and not refer at that stage. As I'm sure you're all aware, the critical period of visual development is within this age group, so particularly critical in babies, and after the age of 8, the visual cortical system is fairly mature. So anything that obscures the visual axis during this time period is potentially amblyogenic. And the younger the child, the more profound consequences this can have in terms of amblyopia. So we're very happy to see any child in this age group with any concerns for risk of amblyopia. But in terms of refractive error, so the range of normal in young children is quite broad. So babies and infants have a huge ability to accommodate. So this is a table from a textbook called Paediatric Ophthalmology and Strabismus by Taylor and Hoyt, and it has limits for when we would prescribe glasses. So, for example, astigmatism of less than 2 diopters under the age of 2, we would tolerate, because astigmatism changes quite a lot during this time period, and the refractive error changes are as the eye is developing normally. So the cornea changes shape, the eye's getting longer. So there's a much higher tolerance of refractive errors in the young age group. So if you do a cyclopedic refraction and they're within these limits, it's probably better not to give glasses and monitor them. In terms of bifocals, we do give bifocals in children. Obviously, some children need bifocals. Any child who's pseudophakic or aphakic will require either a bifocal or a varifocal correction. And we do prescribe bifocals for children with a near esotropia that is corrected with an additional add for near, with the long-term aim of weaning them off those glasses. Also, there's a small group of patients who have poor accommodation and have a lag on dynamic retinoscopy. For example, children with trisomy 21 who may benefit from bifocals, but it's the minority of patients really who have bifocals, and we wouldn't really expect them to have bifocals prescribed in the community. It's normally started in the hospital and then continued as necessary. So I'm just going to talk through some other common conditions or important things not to miss. So an abnormal red reflex in a newborn or an infant, the main things to think about are white reflex could be a retinoblastoma, obviously life-threatening without treatment, and congenital cataracts. So any kind of abnormal red reflex, even if it's very, very subtle, we would want an urgent referral to the ophthalmology clinic, and we will aim to see within 2 weeks. Conjunctivitis in children. So within the first 28 days of life, this is termed neonatal conjunctivitis, and there's a risk of chlamydia and gonorrhea causing their conjunctivitis, which can be sight-threatening. Therefore, any purulent discharge in this age group needs urgent treatment and swabbing. So if you're an optician in the community, that would go straight to A&E. The baby would need a systemic workup and likely to need systemic treatment and to be treated empirically if they have purulent discharge, and not wait for the swab results to come back. Conjunctivitis in this age group is incredibly common, and the majority of babies don't have chlamydia or gonorrhea or herpes simplex. So if the baby has mild crusting, has white eyes, or very, very mild injection of their conjunctiva, but a completely clear cornea, and just particularly sticky in the mornings, then they obviously don't need to go straight to A&E, but it would be sensible to refer to the GP to get a swab of their conjunctivitis, just in case it is an early chlamydia or gonorrhea. And they could get chloramphenicol treatment, but if it's bacterial, then it will be self-limiting. But beyond the age of 28 days, the most common causes are bacterial, as I said, which is self-limiting, and viral conjunctivitis, which normally does not require any treatment. But any severe conjunctivitis, we're obviously happy to see. In terms of amblyopia, so if a child has a high refractive error and reduced corrected visual acuity, then we would like them to have the full cycloplegic refraction prescribed, and then for them to be referred to the hospital eye service. Sometimes we find that children are given a reduced prescription for tolerance, but I don't think that's always necessary, as it sometimes is in older children. So in younger children, the full cycloplegic refraction is a good idea. In patients with anisometropic amblyopia, we either want the full cycloplegic refraction prescribed or the difference in the refractive error prescribed if they're mildly hypermetropic in one eye, for example. And then we would prefer it if we start the patching in the hospital eye service after they've had an orthoptic review. So please don't start patching in the community. I don't think that's a common scenario, but yeah, it's important, because sometimes parents might be keen to start both at the same time, but we do like to see them after they've had glasses adaptation before starting occlusion or atropine treatment. And in strabismic amblyopia, as I'm sure you all know, but just to recap, if the patient has a divergent deviation and a myopic prescription, then we'd like the full myopic prescription to be prescribed. If the patient's esophoric or esotropic and hypermetropic, then we'd like the full hypermetropic prescription prescribed. If the patient is exophoric or exotropic and they have a hypermetropic prescription, then please prescribe a reduced prescription. And similarly, if the patient's esophoric or esotropic with a myopic prescription, then please prescribe the minimum amount of myopic prescription that you can, and refer to the hospital eye service. Obviously, the vision is the most important thing, so that is the priority with any patients with strabismic amblyopia, and the squint does come second to their visual acuity. So if they end up needing, say, a hypermetropic correction, and it makes their exophoria less well controlled, but then is required to improve their vision, then we would give those the glasses that they need and do patching as necessary, and then treat the squint as necessary. And we do like to see all children with strabismus or abnormal eye movements in the hospital eye service, and we would not like any children to be prescribed prisms before we see them, but glasses, please always prescribe glasses. In terms of the squint, it's really useful in referral letters to know the onset, whether it's a constant or intermittent squint, whether it's comitant or concomitant, whether the child's any double vision. So children over the age of 5 always ask about double vision. They may not volunteer it, but it's very, very important to know. Also what their eye movements look like, whether there's any nystagmus or manifest latent nystagmus, and slit lamp examination, including frontal examination, whether their discs look healthy, which is obviously incredibly important for any child with a convergent squint who could potentially have a false localizing sign of a 6th nerve palsy, and could have papilledema accompanying their squint. If it's difficult to get a frontal examination, red reflex is always very important to write on the referral letter, because a clear red reflex at least tells us that they have clear media, which is very important. I've just put down this website, www.squintclinic.com, which is very useful for parents if they want any further information about squints in childhood. It's got lots of useful information and some useful videos, so we often recommend that to children and their parents. Allergic eye disease. So we see a lot of patients with seasonal allergic conjunctivitis and perennial allergic conjunctivitis. It's sometimes difficult to know exactly which allergen they are particularly allergic to, but as a general rule, seasonal tends to be pollen, and perennial tends to be house dust mites. So you can always advise some measures to try and reduce exposure to those allergens. And topical antihistamines, so a Patanol twice a day to both eyes is our first line treatment, and it is very safe, very, very well tolerated, and doesn't require any additional monitoring. So I would have a very low threshold for prescribing a Patanol to any child with itchy eyes and allergic conjunctivitis symptoms. And they can have additional oral antihistamines if required, and nasal sprays if they have rhinitis can also be obtained from the GP. In the BNF, it does say that patients need a break when they've been on a Patanol. I think it's for after 3 or 4 months. And this is because a Patanol contains BAC, but actually it's very well tolerated, and we have a lot of patients who are on a Patanol for twice a day, 12 months of the year. So it's not always necessary, and the most important thing is that their allergic conjunctivitis is controlled. So what not to miss in allergic conjunctivitis, so vernal keratoconjunctivitis, patients can have Trantus dots, so limbitis, they can have giant papillae under their upper eyelid on the subtarsal conjunctiva, and they can develop shield ulcers. These patients can be really, really symptomatic, so they should all be on a Patanol twice a day, but they may require additional treatment, so we'd like to see them in the hospital eye service, because you want to avoid shield ulcers, and also this can have quite a big impact on their quality of life. So if you see any of those signs, please do refer them to us. And also patients with atopic keratoconjunctivitis, so patients who have normally quite severe eczema, periorbital eczema, a chronic red eye, they can have quite a lot of cicatricial changes to their conjunctiva and to their cornea, and they can get corneal vascularization, and they can also develop anterior cataracts. So they need to have their periorbital eczema controlled, either with emollients. If they're on topical steroids around the eye, they need their intraocular pressure monitoring, and they should be on a Patanol twice a day, and they may require additional treatments such as tacrolimus ointment, which we'd start in the hospital. So please refer them if necessary. We see a lot of patients get chalazions, and patients can get multiple chalasia, and they look very, very unsightly. Parents are very, very concerned about them. But if the patients have a white eye and a completely clear cornea, then it is best to wait for them to resolve. So sometimes they can take 2 years to resolve. We can do an INC chalazion. It would require a general anaesthetic in the majority of patients who are young. Older children, we can sometimes do under a local anaesthetic, but that causes a scarring on their inner eyelid, and with time, the majority resolves spontaneously. So if it's chalazion, we advise hot compresses. However, if the hot compresses haven't worked for a few months, they are unlikely to work. And sometimes it is just time that's required to wait for these to resolve. However, some patients with recurrent chalazion have significant blepharokeratoconjunctivitis, which can cause corneal scarring and corneal vascularization and loss of vision. And so it's very important to refer patients with any chronic, it can be quite mild conjunctivitis, but if they have a chronic pink eye, slight watering, it can go on for months and months. If they've got any sign of corneal vascularization, then we do need to see them, because they do need to have their keratitis under control before it causes scarring. It can cause irregular astigmatism, but also you can get scars in the visual axis. So this is it is sight threatening. And the main differential here is herpes simplex epithelial keratitis, which has a completely different treatment. So it's important to be sure of your diagnosis before starting topical steroids for blepharokeratoconjunctivitis. If they do have a herpes simplex epithelial keratitis and you start topical steroids, you can cause a geographic ulcer. So yeah, that's the main differential. It's always safer to treat for herpes simplex keratitis and then start steroids if it's not resolved, if there's any uncertainty. But we're very happy to see. Nasolacrimal duct massage. It's quite common for children to have stenosis or narrowing of their nasolacrimal duct opening into their nose, and a lot of children have watery eyes, sticky eyes, usually since birth, and it can take up to the age of 1 for this to resolve spontaneously. It does resolve spontaneously in the majority of children, so about 90-95% of children who have this problem resolve without any surgical intervention. But we do advise nasolacrimal duct massage. This is helpful for 2 main reasons. So it encourages anything that is stagnant in the nasolacrimal sac to move. So it might come out via the punctum and go into the eye, which doesn't look very nice for parents, but it means that there isn't anything sitting there in the nasolacrimal sac, which is an infection risk. And also it puts pressure on the opening into the nose. So it can encourage the opening of the nasolacrimal duct into the nose. So we advise nasolacrimal duct massage 2 hourly. So, quite frequently. This might not be possible, especially if the children are at nursery, but really frequent nasolacrimal duct massage. So doing it once a day is better than nothing, but really frequent nasolacrimal duct massage can be really helpful, if anything, just to reduce the risk of infection, but also encourage its resolution. And obviously the risk of having a nasolacrimal duct obstruction is getting an infection. So an infection of the nasolacrimal sites is acute dacryocystitis cystitis, and this can spread to a periorbital cellulitis and frequently requires systemic antibiotics. and can be really quite uncomfortable. But that's what not to miss is an infection. Some patients who present with a watery eye can have paediatric glaucoma, and it is important to think of this as a differential for any child under the age of 1 who's presenting with watery eyes, and they often complain of photophobia and eye closure in the sun. There's signs to look out for are difference in size of the eye, look for Harb striae, and obviously look at the optic disc and see if there's any disc asymmetry if possible. But any suspicion of paediatric glaucoma we want to see urgently. And papilledema, we do get a lot of patients who are referred with suspected papilledema, and we're very happy to see these patients because mild papilledema can be quite subtle, and you can have blurring of the disc margin, maybe just on one side. You can see some Passon's lines sometimes, circumferentially from the disc, but not always. Moderate papilledema, when you get blurring of the retinal vasculature coming out of the optic disc, is more obvious, and obviously severe papilledema is pretty easy to see if you've got a good view of the optic disc. So any patient with severe disc swelling in both eyes and suspected papilledema obviously needs to be referred urgently to the nearest A&E department because they need urgent imaging and assessment of their potentially raised intracranial pressure. Patients with mild papilledema, it can be difficult sometimes to differentiate between mild papilledema and pseudopapilledema. So here's an example of pseudopapilledema secondary to optic dysdrusen. So sometimes you can see the dysdrusen if they're superficial, and you can see the way that the retinal vasculature curves in a different way around the optic dysdrusen. There's typically not so much of a cup in these eyes, but it can sometimes be quite difficult. If patients are referred to the hospital, we do multimodal imaging essentially, and if you do have an OCT in your practice, then that is very, very helpful. Sometimes you can see optic dysdrusen on an OCT disc profile slice, but not always. Sometimes we do a B scan to look for optic dysdrusen, which is helpful, but you can get optic dysdrusen and mild papilledema, so the two are not mutually exclusive. And it's very difficult just to look at the OCT disc profile slice and say this is papilledema or this is pseudopapilledema, and it really is taking everything into context and working out what the likelihood is of it being papilledema or pseudopapilledema, and then working out whether investigations are justified or whether we should monitor clinically. So what we really need to know in referrals from elsewhere are, do they have any signs and symptoms of raised intracranial pressure? So that's, do they have any headache with diurnal variation? Is there any associated nausea? Is there any vomiting? Is there any pulsatile tinnitus? You might need to specifically ask for that. Any visual obscurations, so complete blackout of vision, even if it's just for a few seconds. Colour vision is very, very useful to know because perhaps they've got an optic neuropathy for another reason, so we do like to know what the colour vision is. Asking about double vision, particularly distance horizontal double vision for whether they've got distance esotropia or any double vision on side gaze, if they've got any signs of a sixth nerve palsy. And then their medical history is very, very important because most children who have raised intracranial pressure have a more complex medical history, not always, but drug history is really important, whether they have anemia, whether they have any renal problems, perhaps they've got hypertension as well, if they've got any developmental abnormalities, all of that is really, really important. If you do have an OCT in your practice, any change in the optic disc profile is very concerning. So we would expect it to be stable. So any child with any suspicion of mild papilledema that has any changes to their OCT disc profile, then obviously please refer. And so here is our pathway for patients with suspected papilledema. So as I said before, if they have any signs or symptoms of raised intracranial pressure, or that's the big concern, and that you can have raised intracranial pressure without having papilledema, all of those patients need to be properly assessed with imaging and a lumbar puncture and review by the paediatricians. If they're asymptomatic with moderate or severe papilledema, then they should be referred to eye casualty for an urgent. Well, if they have severe papilledema, it's also reasonable to refer them straight to A&E. But normally they come through eye casualty, and then we would refer on if we agree with severe papilledema. We also check their blood pressure to make sure it's not malignant hypertension. And then we can refer on. If they're asymptomatic with suspected mild papilledema, then, and the main question is whether they've got pseudopapilledema or mild papilledema, but they've got normal optic nerve function, so full colour vision, excellent vision, full visual field, if you can do that on the child, and they're completely asymptomatic, then we either see them in our orthooptic-led suspicious disc clinic, where they get multimodal imaging and virtual review by me or one of my colleagues, or we see them in the paediatric ophthalmology clinic, and we review them then. And I think that's a safe pathway, because the patients who lose vision are patients with moderate or severe papilledema, and obviously we don't want to miss any intracranial pathology, but mild papilledema on its own with no other symptoms at all, completely fit and well child, any small delay in them coming to the paediatric ophthalmology clinic is unlikely to result in them coming to any additional harm. So that is what we would suggest. Thank you very much for listening.